So only podiatrists can use functional foot typing, and when they're using it, they have experiential and professional skills to offer educate. We're the only ones with a biomechanical practice, all of us. We're the only ones with at least 3 years of undergrad biomechanical training. We're the only ones that give biomechanical postgraduate training. We are the closed chain specialist, and we should be driving this home to the medical community as our place in the, I don't know what you'd say, in the team, in the medical team. Everybody, on the internet, they'll mail you a set of foam, you put your foot in the foam, you send it back, you get your orthotic, it's $129. Why should I pay a podiatrist $600 to do the same thing? I can't argue with that. And again, God is out of the picture. It's no longer that I'm the doctor with this magic that's going on. So, in architecture, we have two triangular trusses connected by a transverse roof. We explained that to you. This is medial and lateral column, and these are the muscles that have to work and function. In architecture, the pillars are symmetrical, the keystone is centered, the voiseurs, what they're called, are related in size, the arch is self-supporting, and weight is evenly distributed. In foot, the pillars are not symmetrical, the keystone is off-centered. In other words, this is short, this is long. I say to patients, if our eyes were in the back of our head, our rear foot, our forefoot would be short, our rear foot would be long, and we'd be walking backwards. Okay? And that really gives them an understanding of the mechanics of what we're talking about. Our bones don't relate in size and shape, it's not self-supporting, and the weight is unevenly distributed. This is a system that's destined to fail. In order to have a lifetime of function, we've given up a lifetime of support. The vault is defined by foot type. It's either centered or off-centered. It controls sagittal and transverse plane pedal collapse and controls mechanical advantage and leverage. What I'm saying is that we've been using frontal plane correction of the rear foot as our basis for biomechanical care, and in reality, most feet do not need frontal plane correction of their rear foot. So we have an optimal functional position. This is an optimal functional position where the foot is centered, and this is an off-centered collapsed functional position of the vault. So I call this method the foot centering theory of biomechanics, and we're talking now about a profiling system with independent evaluation of the rear foot and forefoot, diagnosing pathology on all three body planes. It identifies subgroups that are likely to predispose specific tissues. So what we're saying here, this is a rigid flexible foot type, and I can show my patient that when they stand up, the back of their foot doesn't change at all, but the front of their foot is lifting up, and ultimately say that this is the bunion foot. In other words, if they have this foot type, they're going to predispose to bunions. It alerts the astute clinician of care that can be rendered adjacent before or after a complaint is encountered. So we're talking about two tests, the supinatory end range of motion. Everything starts in root neutral position. You palpate the subtalar joint. You load the fifth metatarsal to imitate the ground with ground reactive force. And now from that position, you forcibly invert the heel. That would be the supinatory end range of motion. And then you forcibly evert the heel. And those are your two tests. In the forefoot, we measure hypermobility of comparing 1 to 2. Well, now we're comparing it 1 to 5. And here, supinatory end range of motion is to forcibly plantarflex the first metatarsal when you're in that position, and pronatory end range of motion lifts it up. So these two tests, when they're taken, you end up with either an inversion or eversion as your first test. In other words, if you did a Dwyer, the person is everted, but most of us are inverted. And now when you're finished, you define the rear foot type as rigid, stable, flexible, or flat. And we'll go over that quickly. And in the forefoot, it's either plantarflexed, online, or dorsiflexed. and that's stable, rigid, stable, flexible, or flat as well. So these tests are open chain tests that give you information on closed chain. So the first test, the rear foot SERM, in other words, when I invert the foot, it tells me how that foot's going to contact the ground. Okay? If it's inverted or everted, that's how it's going to contact the ground. When I do my perm and I fully pronate the foot, it tells me where that foot's going to be in mid-stance, relatively early mid-stance. In the forefoot, when I plantar-flex the ray, it tells me where the foot's going to be, the forefoot's going to be in mid-stance. And when I dorsiflex the ray and lift it up, it tells me where it's going to be in propulsive phase. So when I have this information, these two tests, I now can interpret how that person's going to be in gait, and I could use that to justify how their gait is. In other words, I could compare the gait to my findings. So the rear foot SERM is determined on the frontal plane. It examines from Root's position. It inverts the rear foot maximally and is measured as inverted or everted. The rear foot perm is the same thing, except you're maximally everting the rear foot. So you're going like this and that. We're going to do a demonstration in a couple of minutes. I think it'll hit home then. Determined on the sagittal plane. In other words, the rear foot is on the frontal plane, the forefoot's on the sagittal plane. Plantar-flex the first ray maximally and measure it as plantar-flexed or dorsiflexed. And the perm, you're pushing upward, and it's measured as either downward, online, or dorsiflexed. The rigid rear foot type is inverted in both moving this way and this way. This is the most common rear foot type. This type is not a pronating rear foot, and therefore anti-pronatory treatment is not going to do any good for it. The stable goes directly to vertical. In other words, it's an inverted foot, and when you move it the other way, it goes to straight under the leg, but no further. And the flexible, that's Root's foot type. That's Kirby's foot type. That's basically, it's inverted, and when you forcibly pronate it, it goes to the other side of vertical, so it's a pronated rear foot. Relatively rare foot. Relatively rare foot. And the flat one is a failed Dwyer or somebody who's 70 years old and been walking on a flexible heel so long that it's permanently everted, and that foot is flat in both open and closed chain, and in both cases, in both tests, it's everted. In the forefoot, the rigid is plantar. This is a Cavus foot. It's plantar-flexed in both tests. You push up on it and it doesn't move to vertical. In the stable, it goes from downward to just on line. This is the healthiest foot type. In the flexible forefoot, that's Dannenberg's foot, functional hallux limitus. It's downward on the first test, and when you push up, it goes higher than the fifth metatarsal. So that's a hypermobile first ray. And again, this is a collapsed forefoot. And the flat is upward on both. Again, this is a club foot. This is it's not a natal foot type. It basically is getting driven upward as so permanently that it becomes fixed in that position. One thing I'd like you to think about, which we all know and I think do, is metatarsus adductus casting. In other words, we take a deformity on the transverse plane and we cast it little by little until it normalizes. That's what our orthotic can do. That's what our foot does in a negative way. If we don't support it, it becomes more and more fixed in an unhealthy position over time. So the 4 rear foot types and the 4 forefoot types create a grid of 16, each with its own characteristics, pathology, precursors, predictions. So there's an open and closed chain presentation. How does the foot look like on and off the ground? There's a lesion pattern. In other words, this is a first metatarsal that's lifting up, and the lesion is sub 1, sub 2. There's an X-ray presentation, changes in the cymaline, changes in the angles of metatarsus adductus and hallux intermetatarsal angle. There's shoe wear changes. There are pedal deformities and associated postural deformities. A collapsed foot, you have an internally rotated knee. So each foot type has a set of characteristics. And I'm showing you one, which is the rigid, and your lesion is first met. They're a very poor shock absorber because they can't pronate very well, so they have low back pain. Their calluses are sub 1, sub 5. Their shoe wear is under the first and on the side. And this is the X-ray, the bullet hole sinus tarsi, the high calcaneal inclination, the high plantarflex met deviation. So each foot type has its own characteristics. So I can give you a set of characteristics. You could give me the foot type, or I could give you the foot type and develop a set of characteristics. So you have the Cavus foot, the bunion foot, the normal foot, the PTDD foot, and the spastic flat foot. We're not treating feet differently. The feet aren't changing, but we're calling them something that is explainable to the patient and making it experiential. So these are the common foot types. The rigid, the rigid flexible is the bunion foot, the normal foot, the collapsed or pronated foot, the PTDD foot, and the spastic flat foot. So to review, the subtalar joint, the CERM is inverted in both in both CERM and PERM. It's plantarflexed in both forefoot CERM and PERM, and this is your rigid. It's relatively the same foot on and off the ground. We won't go over the characteristics. This would be the rigid flexible. This is a relatively arched foot, but when it stands up, I don't know if you can see it, the rear foot is not changing very much, but it's developing the bunion. So when this person's facing, you're behind them looking at their tendo Achilles, it's straight. And when you look at this foot as a collapsed foot on the ground, you may automatically say by habit that it's a pronated foot, but it doesn't have a Helbing sign. It doesn't have a C-shaped tendo Achilles. This is the stable, which is it collapses only a little bit, no calluses, no problems, good function, healthy, very rare, 7, 10, 15 in my 40-year career. This is the flexible, which is the pure pronated foot, and why I'm showing it from above is this rear foot is collapsed. This does not necessarily form a bunion, okay? This is collapsed from the time it's very young. Doesn't really develop plantar fasciitis. That plantar fascia is stretched when they're 10 years old, 15 years old. The flat again is an older person who's walked on a collapsed foot so long that it's permanently collapsed. Okay? Questions? It identifies the subgroups likely to predispose specific tissues or groups of tissues to pathological levels of stress.